I decided that I needed to learn more on how to be a clinician. What are those competencies that I need to know that are going to make me a good clinician virtually? And 2 years later, here I am, very involved in education. I put together an elective course for the fourth-year medical students at UCF. It's a 2 weeks elective. It's online, and they come and see me at the clinic once a week, or now virtually because of the emergency. Aside from the elective, I do have my own practice. I provide independent physician contracts to different entities in different states, Texas, Florida, Michigan, Pennsylvania, Indiana, and Missouri. So over the past 4 years, I've acquired plenty of expertise in both clinical and education. And that's what mostly the educational part, that's what I want to share with you. This is my contact information. Feel free to reach out. And I do have a website that it's mostly a resource website more than anything. This is the information of my practice. In 2016, I developed a business for my practice called Remote Medical Care, but it's a solo practice. And again, I don't have my own patients. I contract my services, and I work for different organizations, and I provide medical care remotely. On the side, I also do some consultation and education, like I said. I want to highlight on my website, there's a tab that's called Telehealth Resources. That's public domain. You don't have to enter your email or anything like that. Just go there, click it. There are a lot of resources for you to research and learn from, guidelines. There are links to different courses and even some of the telemedicine fellowships that are in existence. You can find those links there. Otherwise, this presentation, or in this presentation, I have nothing to disclose. I'm truly doing this because I love to share what I know and educate, but no one's paying me for this. I have no gain from this other than the pleasure that I have in teaching you. So this is what's going to happen. We're going to talk about practice standards and HIPAA. We'll have a break, and then we're going to talk about the licensing, regulation, and telemedicine, payments, just briefly, question and answers, then ethics, quality, safety, rural health, cultural competency in telemedicine. And then we'll have another break for questions. Then we're going to talk about digital communication and website manner, or telemedicine etiquette, the virtual physical exam, and then some more questions. And then we'll take a break after that. Maybe that will be about an hour at that point. We can take a break, go to a potty or go and get some water or whatever, come back, and then do session number 2, which is more related to the education of telehealth and telemedicine to our students. So we'll go about the rationale, barriers to telemedicine education, what the American Medical Association and the AAMC are doing. So anyways, those are the slides. That's what we'll do at the end. Then I'm going to give examples on how to integrate these competencies in the curriculum at the preclinical level, clinical level, and graduate level. And so let's see here. Perfect. So let's go ahead and get started. Now, so Telemedicine, there are 1,000 definitions out there. So I always talk about the American Telemedicine Association definition because it is the standard. I need to also clarify that when I say telemedicine, it's also for the purposes of the presentation. We can use telehealth and telemedicine. We can exchange those two terms. They should mean the same for the purposes of the presentation. There are differences between what telehealth is and what telemedicine is, but I don't want to get into the specific of that. So you'll see that I say telehealth sometimes, telemedicine sometimes, so it means the same. But for the ATA, telemedicine is the use of medical information exchanged from one site to another via electronic communications to improve patients' health status. Their definition is actually a lot longer than this, but I just wanted to mention that. And then I'm going to show you my definition. This is what I tell people what I do. And I provide healthcare services remotely using information and communication technology. And that's really, it boils down to that. Is how can I provide medical care, healthcare services from point A to point B, anywhere in the world, using communication technology. And that's what this really is. Now, a few pointers before we get going with the presentation. I just want to point out that telemedicine is not a service, okay? It's a service provision modality. And I say this because when I see my patients remotely, I provide medical care to my patients, primary care. And I prescribe and I tell them what to do regarding their care. I don't sell them my telemedicine service. It's not a service. It's a platform that I use in order to communicate. So we should avoid using the term telemedicine service. No one provides telemedicine services. So anyways, that's the point of this slide. The second slide is telemedicine is not a replacement, or no one at least I don't think of telemedicine as a replacement for in-person or traditional care, right? I decided that I wanted to do telemedicine 100% of my time, but that's not the case for everybody. Instead, telemedicine is just a digital tool that we can integrate into the workflow of our existing practices to improve quality, to improve efficiency, that sort of thing. Telemedicine is not a specialty. So I don't specialize in telemedicine. I specialize in family medicine, but I deliver family medicine care via telemedicine. All healthcare providers, whatever you do, nursing, physical therapy, social work, counseling, medicine, from here on, especially given the circumstances of this emergency that we have, from here on, all healthcare providers should have basic knowledge and competency to deliver healthcare services virtually. So it's not specialty, we just have to have the competencies and the knowledge on how to do it, okay? With that said, you will see in the literature the concept of the medical virtualist. And this refers to healthcare providers who spend the majority of their time caring for patients. So in this case, I'm a medical virtualist, but medical virtualist competencies should be known by all providers nevertheless. Okay, anyone who is expected to provide virtual care should have these same competencies. So when you see this word or this concept of the medical virtualist, it shouldn't be thought as a specialty, but instead it's a description of professionals who spend most of their time providing care virtually. Okay, so let's move on then with the first session, the competencies for the medical virtualist. And so first, let's talk about the practice standards, right? All states have telemedicine statutes, and their medical boards have created these statutes directed at healthcare providers to help them understand how to practice virtual medicine remotely. So for example, Florida has telemedicine practice statutes in place, and you can actually go to the Department of Health or Department of State page and download it. That's their link. You can actually download the PDF. I added the link there. That you can find that in the telehealth resources in my website as well. It's a list of things that physicians are expected or providers are expected to do to practice virtual medicine. Now, telemedicine practice standards are different from what's called the medical standard of care. Telemedicine practice standards, for the most part, don't apply to traditional or in-person care. These are rules that are mainly designed for the virtual environment. And so I'm going to touch on 4 of these standards. I've taken this mostly from the actual Florida statutes. I would say that if you look at the second bullet, the patient-informed consent, Florida actually doesn't require healthcare providers to obtain a telehealth informed consent for medical services, but I'll get to that in a few slides. But anyways, we're going to discuss the virtual physician-patient relationship. We'll talk about the informed consent, what it is and what needs to be included there, what is a valid online prescription, and we'll talk about regulations for the prescription of controlled substances. So per the American Medical Association, all states allow for the establishment of a valid physician-patient relationship. The physician-patient relationship in terms of telehealth or telemedicine is essential for the provision of medical care. And without a proper relationship, we shouldn't prescribe medications and we shouldn't bill for services. So those things are important. We need to establish, before we even start asking the patient questions, we should make sure that we have an established relationship with the patient. And so both the American Medical Association and the Federation of State Medical Boards, they have developed these guidelines where they have these requirements, very structured requirements on how to document, how to establish a patient-physician relationship virtually. And so I made this little table here. One of the criteria that must be met is that before the visit, the provider has to confirm the location of the patient, whether this is at home, at work, at the clubhouse, at the beach, whatever the patient is. Also, the state where the patient is. Okay, so location, physical location, and state location. And also, I verify the patient's identity. So usually, that means we can verify the patient's name, full name, and date of birth. This is only done once. So this is only done, the establishment of this physician-patient relationship, it's done at the first visit when you first meet the patient. So these requirements only apply on that initial visit when you are actually meeting the patient online for the first time. Once you establish the relationship, then you don't have to repeat these steps. So you do that first step, and then the second step or the second criteria is disclosing the provider's identity and credentials. So when I meet a patient, I let them know, my name is William Gonzalez. I am a medical doctor, board certified in family medicine. So I disclose my name and my credentials. That's perfect. And then the third step before we start the visit is that I have to make sure that I obtain or I get an informed consent from the patient before we do the visit. This is what's called the telemedicine informed consent. So these three criteria are part of the guidelines. I included the references at the bottom. So the telehealth informed consent is a big thing. For the most part, most telemedicine or telehealth providers make this consent part of the intake. So as soon as a patient is enrolling or registering to be a patient within the organization, these organizations already have this consent in place, so the patient signs it right away. Therefore, providers, when they're meeting the patients for the first time, when I'm meeting a patient for the first time, for the most part, I don't have to consent the patients because they have already been consented. So what I do is, do you have any questions about the visit before we start? And that's kind of the workflow that I have. Nonetheless, let's assume that I'm seeing a patient for the first time and the patient has not been consented, right? What do I have to do to obtain a verbal consent from the patient before we start the visit? First, I would need to tell the patient that this consent, even if they consent now, it can be revocable. That's usually the first thing that is mentioned in the consent. They can revoke it and then reestablish it at any point. Number two, we should define telemedicine for the patient and what are the possible benefits. You know, I can provide remote care conveniently while you're close to home or work, but also we should explain the possible risks or possible consequences, including things like breach of privacy because of the security of the technology is not as good, or risks of, for example, if I do the visit with the patient, there's the risk that at the end of the visit, I might still need to refer the patient to in-personal care. So I have to let the patient know from the get-go that even though we are doing the visit virtually, I might still need to refer the patient for in-personal care. And I really make a big point out of that because sometimes patients have expectations of greatness when they are doing these virtual visits, and then they're kind of frustrated at the end when I say, well, I'm sorry, I can't help you. You need to go and see your doctor because of the limitations. So make sure they understand that. Part of the consent should also be that patients should understand that their health information remains private, that we have the same HIPAA standards in person or virtual, and that should be in the consent. The consent should also say that patients will have access to the telemedicine visit summaries and notes and whatnot, the same way we do in person. And then at the end, they should agree and accept. Either they sign or they give you a verbal accept, okay? So as long as you touch on these points and the patient agrees and understands and consents, then that's the consent. Then you can document that in the chart. Even if you don't have a signed hard copy, as long as the patient verbally agrees, I can document it, and that counts. a valid online prescription. So prescribing online is regulated. Now, when we have patients that are established in our office, right? If I have my primary care clinic, and so happens that I'm seeing my patient online today because we're doing social distancing, because I already have a relationship with my patient from my practice, I can send the refills or send the prescriptions via e-script without any problems. The problem is when there are new patients that I meet online, if I have not established a relationship with these patients, I should not send prescriptions. So for example, someone that sends me an email saying, hey, Dr. Gonzalez, my wife is your patient. Now I have a problem and I need an antibiotic. Can you send one to our pharmacy? No, that's illegal because I don't have a relationship with that patient. And it, you might say, well, that makes, that's common sense. But the point is that there has to be, we have to go through that process of establishing a virtual patient-physician relationship before we can prescribe these medications. They have to be for a legitimate medical purpose, right? We have to follow the proper standard of care, and this needs to be documented properly in the medical record, right? We can't just treat people and just not document it. So that's also standard of care. Now, controlled substances. The controlled substances, it's illegal to prescribe controlled substances online. But there are exceptions to it, and it's regulated by what's called the Ryan-Haidt Act from 2008. So under no circumstances, any healthcare provider should prescribe controlled substances via electronic means unless the patient already has a previous in-person examination. So again, going back to my patient from the clinic, let's say my patient just had gallbladder surgery and is having a lot of pain and doesn't have any medication for pain, but this patient is my patient from the clinic. I know the patient, we've met many times. It is completely legal to send him or her a prescription for some Norco for a couple of days because I already have that relationship with the patient. If I have a patient that I just met online and this patient is telling me, well, my doctor, or I had surgery yesterday, but my doctor is out of the office and I can't get in touch with them, can you send me a prescription? The answer is no, because even though I can establish a virtual relationship with the patient, I have to meet the requirement of an in-person physical exam. And this only applies for controlled substances. And because I can't do an in-person physical exam virtually, then I cannot prescribe controlled substances. Now, there are 7 exceptions to the previous in-person examination. And so I mentioned 2 here that apply. One is what's called a DEA special registration, and that is something, is a regulation that the DEA is currently working on to design a registry where certain physicians will be able to apply and get a registration from the DEA. It's like an additional DEA number to allow these physicians to prescribe controlled substances via telemedicine without the in-person examination. So that's not yet a thing, but it's being worked on. One of the other exceptions is public health emergencies. So right now, during the COVID emergency, it is legal, it is allowed for as long as the public health emergency continues, it is allowed to prescribe controlled substances via telemedicine, even if I don't have an in-person evaluation with the patient. Now, it is important to understand that I still have to prescribe the medications for a valid reason, a legitimate reason, and it has to be following the standard of care. So I can't prescribe Norco for a month. I still have to comply with the regulation of prescriptions, 3 days for acute pain and so forth, whatnot. So that's that. And then before our first question and answer break, I want to touch on HIPAA. Now, HIPAA and privacy in telemedicine, HIPAA and privacy should be treated the same. It's the same privacy standards, whether you're providing care in person or care virtually. The standards should be held at the same level, okay? Personal health information should be protected regardless. The difference is that the technology component comes into play. So as providers, we need to make sure that the technology that we are using has the security features that are going to allow us to keep that information private. For example, you can use electronic medical records, or you can use telemedicine platforms where you can exchange files and exchange information, as long as these entities have proper security designs like encryption, password protections, and then and as long as there is what's called a business agreement or business associate agreement, then that should be fine. So most of us use electronic medical records to store patient information and to share patient information. Those technologies comply with the many layers of security, including encryption and password protection and whatnot. So, and then the last point that I want to make is that aside from making sure that you have a business associates agreement with these technology companies, we also need to understand that certain technologies like Zoom, right now we're using Zoom for this meeting. As long as I am not sharing or using this platform to share patient information, data, meaning as long as I'm not typing anything into the platform, and as long as I'm not attaching documents or sharing documents through the platform, then I don't need a BAA or a business associate agreement to use this platform to just talk to a patient. As long as I know or understand that Zoom has encryption and has password protection, which my version of Zoom does. So I use this Zoom platform to talk to my patients remotely, and then I use a medical record that is separate from Zoom, where I do the texting and the emailing and all of that. But I don't have a business associates agreement with Zoom. I don't need it because HIPAA, because Zoom doesn't store personal information, HIPAA doesn't apply to Zoom in this sense, as long as I'm not using it to communicate or share patient information. Hope that makes sense. But anyway, I just wanted to make that point because sometimes people say, oh, is Zoom HIPAA compliant? It doesn't apply to Zoom as long as, like I said, as long as there's no information exchanged. Now, so another very important competency is telemedicine licensing and regulation. Now, under normal circumstances, state boards control state boards control who can practice medicine within the state jurisdiction. And for telemedicine, those licensing rules are based on the location of the patient at the time of the consult. So an example is, let's say I have Mr. Gonzalez, that is my patient here in Florida, but Mr. Gonzalez has been living in California for the past 4 months. And now he's calling me because he has an issue and he needs me to help him. The problem is Mr. Gonzalez is now in California. I am not licensed in California. So I cannot treat Mr. Gonzalez or help Mr. Gonzalez for an acute problem because of the jurisdiction. There are some exceptions of this. For example, there are some exceptions to the state and licensing rules. So one of them is a public or medical emergency, where right now many states are just providing reciprocity for healthcare providers and are allowing physicians that are licensed in at least one state to practice within their state. For example, New York is doing that. I've been seeing patients in New York, in Delaware, in Iowa, there's one more, Vermont. And I'm not licensed in any of those states, but the state allows me to do that, and I am within the regulation because there is a medical emergency, and the state regulations allow for that. So that's an exception. Now, another exception is follow-up care. So in going back to the case of Mr. Gonzalez in California, if Mr. Gonzalez was calling me because he ran out of lisinopril and he needs a refill, his hypertension is something that I treat already at the clinic here in Florida. So it would be okay for me to send him a refill for lisinopril because that's follow-up care. He just ran out of the medication. At some point, he's going to come back and see me at the office, and we're going to continue our relationship. But that's valid, okay? Another example is a patient who goes out of state for a surgical procedure, for example. And then that patient now returns home to Florida, but the surgeon is in Michigan, for example. The surgeon can follow up with the patient here in Florida as a surgical follow-up, and that's allowed. So the surgeon is not breaking any rules as long as the care is for follow-up care. And the third exception is peer-to-peer consultations. So Dr. Lewis is in Washington State, and he has a complicated patient, and he wants to ask me about his patient. As long as I'm not talking directly to the patient and telling the patient what to do, and as long as I'm only talking with Dr. Louis, then that's allowed. That's not a problem. That's peer-to-peer consultation. But the important thing is that for a telemedicine visit, the location of the patient at the time of the visit dictates what state regulates the visit. There are some attempts going on to kind of streamline this process. One of them is the Interstate Medical Licensure Compact. Right now there are 29 states plus DC plus Guam that have joined this compact. And what this is an expedite way to get medical licenses. I still need to apply for the state license. I still need to pay and maintain and follow up with continued education, but it's an expedite way to do it. So as long as I am licensed in one of the states within the compact, then I can apply for other licenses within the compact in a more convenient way. But it doesn't solve the issue of having or needing to have multiple medical licenses. Many states actually have what's called a special telemedicine license. And what this is states that actually provide, states that actually provide a medical license for telemedicine purposes only. And I'll give you, Florida is one of them. And that's that Florida HB 23 Senate bill allows for physicians outside of the state to practice in Florida through a special telemedicine license. Texas, Oregon, Alabama has one. So there are many states that have that. The only thing is that most of these states that provide this special telemedicine license have restrictions, and one of them is that the physician or provider cannot practice within the state. So it's only for telemedicine. So if I had a special license in Texas, I cannot go to Texas and open a practice there. That's illegal. Coverage and payment. So this is important to know because under normal circumstances, again, not COVID, but under normal circumstances, Medicare and CMS have specific requirements that have to be met before CMS can pay for telehealth services. And there are three requirements. One is what's called a geographic restriction or an eligible originating site. The other one is an eligible provider requirement, which is what provider is at the distant site, and then what type of modality is required for the visit. So for the geographic restriction, the patient, first of all, the patient has to be in a qualifying rural health professional shortage area. So you can't provide telemedicine services to Medicare patients who are not in a shortage area under normal circumstances. And also the patient must be located in a qualifying facility within that shortage area. Now, obviously, during this COVID emergency, CMS has removed temporarily this geographic restriction so the patients can be home and this patient can be in the middle of downtown Orlando and they can receive telehealth, telemedicine services and be paid for. I added this slide. This is for your reference. If you want to know if your practice is located within a professional shortage area, you can go to this website. Either it gives you information by county or by address. So you can enter the address of your practice and see if your practice address qualifies for the professional shortage area requirement. Under normal circumstances, there are exceptions to the geographic restriction. One of them is for the treatment of substance use. So patients can be home and can be located anywhere and receive, these are Medicare patients, and receive medical care via telemedicine for the treatment of substance use disorder and also for mental health disorders related to the substance use. Also, the treatment of acute stroke is an exception. Patients can receive stroke treatment at home. So the ambulance can come and that can happen. And patients receiving dialysis, either at home or at different dialysis centers. As long as it's for dialysis, the geographic restriction doesn't apply. Now, there are restrictions in terms of what healthcare professionals can provide telemedicine services for Medicare patients. And there's a list of them. I always say that Medicare includes most healthcare providers with the exception of pharmacists and physical therapists. If you go I added the resource on the slide. If you go to that link, you can download the telehealth services brochure, and you can reference that list of providers that are eligible to provide services. It includes physicians, nurse practitioners, physician assistants, midwives, psychologists, social workers, dietitians, nutritionists, and so forth. And to provide medical care via telemedicine for CMS patients, it has to be a live video interaction. It cannot be asynchronous. That is the same during a public health emergency or during normal circumstances. And I want to mention this one thing. States, or a few states, have passed what's called payment parity laws. These laws apply to private healthcare insurers, and these laws are designed to promote patient access. Okay, and what these laws do is these laws require health insurance companies to pay for medical services delivered via telehealth or telemedicine at the same rate as they pay in person. So states who have passed legislation for payment parity laws, health insurances in those states have to pay the same amount of money, and they have to cover the same services, whether it's in person or via telemedicine. The state of Florida doesn't have parity laws, and that's a big problem. That's why Florida, or telemedicine in Florida, is lagging, because there's still a lot of problems with insurance companies wanting to reimburse for telemedicine services. They only pay at a percentage, or sometimes they deny the service completely. So unless we have parity laws in Florida, there's going to be a lot of barriers for telemedicine in Florida. Okay, so moving on, I want to touch the next few slides. I'm going to talk about ethics. I'm going to talk about rural health. I'm going to touch on quality and safety, and I'm going to touch on cultural competency. You know, all of these things, it's like they're all connected, right? So I just want to touch on these topics. It's important for us as providers to understand these issues, but I think more importantly, it's important for us as educators to understand these issues, and we should be able to then educate our students in these issues, because these are really important. So the American Medical Association actually adopted policy, this was in 2017, for the ethical practice in telemedicine. And among other issues, physicians should understand that the patient's privacy is of most importance, whether we're doing a telemedicine visit or in personal care. The physician should also be familiar with the security of the technology that I am using. Okay, I should know what sort of technology and security level I'm using. Am I using something that is meeting standard? Am I using something that is substandard and I'm risking breach of security? Okay, at the end of the day, that's my responsibility. So as a physician, I need to understand privacy, security, and make sure that the information that I'm entering and I'm getting from this interview is preserved in a medical record. It's the integrity of the conversation and the information is adequate, and I'm including it in the patient's medical record. Physicians must be aware of the limitations of these services. So just because I am providing medical care via telemedicine doesn't allow me to just wing it, right? if I cannot meet the standard of care in a telemedicine visit, then that's it. I can't provide medical care. I have to tell the patient, sorry, there are limitations, and explain that to the patient and send them to see their doctors, right? So it's unethical to just wing it, obviously. Standard of care must be maintained either in virtual or in person. And again, touching back on the first bullet, physicians must be proficient in the use of these technologies, right? So I can't just say, oh, I'm going to install this program and I'm going to start seeing patients, and whatever happens, I'll figure it out along the way. That is unacceptable. You should be able to help the patient. If the patient has technical difficulties, I should be competent in the technology and how to use it and how to help the patient troubleshoot the technology as well. Next bullet, I must thoroughly establish a physician-patient relationship. We talked about that. And at all times, I must comply with regulation, right? Licensing regulation, prescription regulations, controlled substance regulation. And well, I just mentioned that. So this is a neat document. You can download it. You can just search AMA policy finder and then type that number at the end, the CME 1.2.12, and read it. It's really interesting. Something that I talk to the students all the time is the digital gap and how that relates to the ethics of telemedicine, right? The basic definition of what the digital gap or the digital divide is a gap or the divide that exists between individuals that have access to the internet and computers and those who don't have that access, right? That's the gap. So individuals who don't have access to computers or software, individuals who don't have access to broadband connectivity. I added that white box at the bottom. 10% of all Americans still lack access to basic broadband connectivity. 25 download and 3 upload is the benchmark. That's pretty low. For most applications nowadays, that doesn't work. So there is an issue with broadband connectivity in 10% of all Americans. And then the other issue is there are people who have access to computers and there are people who have access to broadband, but don't have the e-health literacy. They don't know how to use the technology. So that also falls within that digital gap. And I always make a point of educating my students about this because as society turns to the internet for civic purposes, business, healthcare, like telemedicine, those individuals that fall within that gap go without the service, right? So that's a disadvantage. It's a type of discrimination. And this is important because if I am planning and designing and implementing a telemedicine program, part of the planning and design, part of it has to be how to deal with this problem. So if my population of patients have issues with low literacy, or maybe they just don't have access to computer, or maybe their community don't have access to broadband, then why am I implementing a telemedicine program? And now these patients are going to go without care. Without care because they can't travel because they're in remote areas, but also without care because they don't have internet and connectivity or don't know how to use it. So the digital gap is a very important point. It should be educated as part of ethics when we're talking about telemedicine. Now, I want to touch on quality and safety, okay, because many times when I'm talking to individuals about telemedicine, the question comes up, how about the quality? How about the safety? Our students also have those questions, okay? Can I provide quality care? Is this safe for the patients? So this is a pediatrics article. Jan, this is from 2016. The article he published that telemedicine has the potential to improve the quality of care and patient safety in pediatrics. And does that, and it does that by improving patient access. It does that by extending provider outreach. It does that by increasing the education for all participants. And also it does that by reducing waste and reducing overuse of resources in healthcare. So, for example, quality of care improves for patients who are in remote areas who don't have access to specialty care, when specialists and subspecialists in a tertiary center can extend their expertise to these communities via telemedicine. Automatically, that increases the quality of care to those patients there, because now they have access to that expertise when before they didn't have it. That's just a very simple example. Now, this study is on safety, okay? And basically, what the study did is they did a non-inferiority study. They took non-acute headache patients and randomized them, half via telemedicine and half in traditional care. And they concluded that telemedicine consultations was as efficient and safe as regular care. So this is a study that is used a lot because of the question of safety and quality and efficiency, and it does compare. Now, on the other hand, this is a VA study. Su et al. This is from 2016. They had 9,300 patients with diabetes. This is within the Veterans Healthcare Administration. They took a total of 4,600 patients were randomized to telemedicine, and 4,600 patients were randomized to traditional care. And the endpoint was the difference between glucose control and hemoglobin A1C. And basically they found out that telemedicine compared to conventional care can be more effective in improving the outcome for diabetic patients. And it makes sense because for chronic disease management, telemedicine always shows to be more effective than traditional in-person care. Most studies that do this find that that's the usual outcome. This is also a very interesting study I added here. This is from 2019, also from the Veterans Administration. It's just a study to illustrate the use of telemedicine use post-disaster. So the conclusion was that telemedicine offers the potential to improve post-disaster access. We saw this, I forgot what year was it, but the hurricane that affected Houston a few years ago, there was a surge in telemedicine usage because these communities affected by the hurricane in Houston were uncommunicated, and the only way they had to reach medical care was via telemedicine. So telehealth does offer the potential to improve access, especially in post-disaster. And we don't have to go far. Right now, in this emergency, many patients are isolated, right? But it's because of the virus and they're just staying home. So we know, we see it, we are practicing that right now, that virtual care does improve the quality during issues of public health emergencies, because patients now can still have access to medical care while they're at home. Rural health. really quick, and basically this is something that I always tell patients. Rural health have issues of, many issues, lack of healthcare infrastructure, lack of healthcare expertise, and many of these communities are far away from healthcare services. So rural communities have distance and geographic barriers. Think in, for example, Alaska. Many of these communities are, disconnected because there's water in between them. So they have to either fly or get on a boat or whatnot. So distance and geographic barriers are a problem in rural communities. Another issue is what's called the geographic maldistribution of physicians, where physicians tend to concentrate in urban areas where the urban tertiary centers are. And that leaves these remote rural communities deficient in medical expertise. So telemedicine can actually, or telehealth, automatically scratches those barriers, because now patients and physicians can connect regardless the distance, regardless those geographic barriers. And even if the physicians are in the urban area and patients are in the rural area, they can still connect, given that there is broadband connectivity and that there are computers and that the patients know how to use it. But adjusting for those issues, telemedicine completely erases those issues that affect rural health. So it does increase quality that way. One more point that I want to make is that just to remind you, in a telemedicine visit, there are always two sites. There's the site where the doctor is, and there's the site where the patient is. So physicians and providers should always be competent when it comes to culture, right? So the physician needs to adjust and understand what are those preferences of these patients. Are these patients with limited English proficiency or limited e-health proficiency, or are these individuals who don't like to use computers much, but they're trying to do their best, right? Physicians need to be able to understand that and adjust to that. And also another point that I always love to make this point is there are social and cultural differences between clinical sites all the time. So I always make the point of me as a physician being here in Orlando, within the Orlando context, within the big city, big amenities context. And then the patient might be in the middle of Idaho, right? And he's a farmer and he goes hunting. And when I connect to this patient's home, I can see that in the background, he has all these animals hanging on the wall, and he has all these guns, and he's actually, he might be even smoking a cigarette while cleaning his shotgun, and he's talking to me in the computer, right? For him or for her, that's their context. For me and for my context, that might be a little bit impressive, but I need to be competent. I need to understand that that's the patient's context, and I need to adapt to that. So teaching students these points and these competencies of cultural issues, social and cultural issues is important as well. And the last part of this first session is digital communication and website manner. So this is basically what's called the etiquette, telemedicine etiquette. So me as a physician, I need to think of myself also as a broadcaster, of someone who's standing in front of a computer and try to look as professional as I can look, right? And so communication and projection, what that stands for is I communicate and I project towards the source where the patient is going to be communicating with me. So in this case, I have this microphone. So even if I look sideways or whatever, you can still hear me. But if my microphone was on the camera, then I would need to project this way. If I project this way because I'm looking at the monitor, the patient might not be able to hear me. So these are things that I teach the students. Project always to the microphone, communicate to the microphone. Using gestures and using hands is okay, as long as you're using it to express emphasis or to make a point, or to kind of lead the patient and help the patient with visual cues and assist with communication. Now that's different from body movement that has no enhancement or no function in the communication. So if I have this habit of moving my shoulder as I talk, or maybe I just kind of talk and I move my legs as I talk just because, see, that can get in the way, because from the patient's perspective, that can be distracting. Or, if I tend to do this all the time, or if I tend to bite my lips or stick out my tongue, or, those sort of things with practice, they need to be corrected, because it actually enhances the communication and it decreases distractions from the patient. Background. With Zoom, you can have whatever background you want now, right? You can have professional looking backgrounds, or you can have a background at the beach, or whatever you want to do. For patient visits, it must be plain and simple. So this is my usual background when I'm seeing patients. It could also be a blue colored drape, a gray colored drape, that works. Avoiding bright colors that might be irritating to the eye, but it should be plain. So no bookcases. As much as possible, avoid having a window as a background, because obviously you don't know what's happening outside, or maybe the light is coming in through the window and it's causing a lot of light reflection, and it might not be the best visual. So windows, for the most part, are usually recommended against as a background. Now, standing in front of a window works. With that said, lighting is another important thing. Right now, as I'm speaking with you, I'm reaching over and I'm touching what's called a soft light. So it's basically a light that shows my face, and it just adds profession, makes me look a little bit more professional. And the patient can see my gestures more clearly and can see my lips and what I'm saying, and that just adds more comfort to the patient. Framing means I'm standing in front of the computer and I am centered, at the camera. I'm centered at the camera, and you can see my shoulders. You can see my shoulders, you can see my head. It's not appropriate if I actually stand right here, or if I'm doing this and you only see half of my face. It's not appropriate if I'm standing 4 meters away and you can hardly see me. So usually an arm length from the camera is proper. And last is the camera. The camera should be fixed and should be at eye level. So looking down into a camera, it doesn't look well, and sometimes it looks almost condescending. As you look down into the camera, it just looks like the physician or the provider is not putting much effort into looking straight into the camera. So the camera should be at eye level and should be fixed. So walking around with my phone, talking to the patient as the phone is bouncing around, that is very uncomfortable and very distracting from the patient's perspective. If the patient does it, then that's okay. But me, being the professional, I want to make sure that I keep these things in mind when I'm doing the visit. And again, that's called the website manner or telemedicine etiquette. Also, clothing, for the most part, things go, everything goes, except using, I added this picture there. Using shirts that have this sort of print or pattern, pinstripes, can be very, very uncomfortable, especially if the resolution is bad. If the patient has a monitor that the resolution is bad, it can be really uncomfortable using pinstripe patterns or busy patterns, like busy flower patterns or busy Hawaiian shirt patterns or things like that. So for the most part, solid colors, or if there is print, should be like just random, simple prints. And last, the last part of this session is going to be the virtual physical examination. Okay, and this is very important to educate the students on because one of the principles of the virtual physical exam is that there has to be an emphasis on the history taken and the observation. Right? We can use electronic peripheral equipment to enhance the physical examination, but that's not required, okay, to do an exam. And also, we always should keep in mind, and we should always remind our students that an adequate examination is not always possible. So many times we have to refer patients for in-person care because telemedicine doesn't allow for the proper examination, and that's important. Now, with that said, I want to show a few articles that I always talk about, and these articles talk about the different contributions that a medical history, a physical examination, and a laboratory investigation can have on making a diagnosis. Peterson et al. In 1992 found that, or reported that 76%, or that the interview and history has a 76% contribution to the initial diagnosis. The examination had only 12% contribution, and laboratory investigation had 11%. So for the most part, most patients were able to be diagnosed initially by history, by an interview. And then and then later in 2000, Roshan found similar numbers. History had 79%, examination 8%, and laboratory investigation 13%. And the point of sharing these articles with you is that telemedicine is a great way, especially video communication, is a great way to do a proper medical interview and to observe. So most patients that we see via telemedicine, the majority of these patients, we should be able to make a good assessment and make an initial diagnosis based on just a history and observation. Some patients would need to be referred out to in-person care. And that is the point of sharing these articles with you. Now, the virtual physical exam has also a certain, I would say, nice things to it. For example, you can connect with the patient remotely and do a home evaluation or evaluate the patient's environment, look at the pantry, do a medication reconciliation while the patient is at home, and they can bring all of these bottles of medications that they have. Also, with virtual examinations, you have the ability to guide the patient to help with the exam, or you can have someone who is a caregiver or a family medicine, or even a facilitator who might be present on site. Those individuals can also help with the examination and facilitate a physical exam for the physician. We just need some ingenuity. So again, the value of the video physical exam lays on the observation. Okay. Like I said, we can use peripheral equipment to enhance, peripheral electronic equipment to enhance the physical exam. And I have a few bullets here that I want to share with you. Now, these equipments are becoming so good and so high, they have so much resolution and have high definition that in the future it's expected that many of these electronic instruments may become the standard of care for diagnosis. So instead of using traditional otoscopes or traditional stethoscopes or whatnot, we might be using these same electronic instruments in the office. It allows for interaction with the patient, and patients can actually see what you're doing or hear what you're hearing, or you can record the findings and give those to the patient for them to share with others later on. And these instruments are regulated by both FDA and CE standards. And this is a list of some of the equipments that we use. So is on telemedicine education, okay, and how we can incorporate these competencies into the curriculum, right? So I'm going to start by using this introduction. Market analysis back in 2019 estimated the value of the telehealth market to be US $267 billion. And despite this growth, it was found that telemedicine education remains noticeably absent from the medical school curriculum. This rapid growth of telemedicine and telehealth has exposed the lack of training in the US to prepare clinicians to provide medical care virtually. So telemedicine education is needed. However, we all know there are barriers to this, right? Number one is that currently there is no official curriculum available for telemedicine education, right? There's no standardized curriculum with competencies to educate our students. So many of the institutions and academic centers that do teach, like UCF, their School of Medicine, many of these institutions teach the students, but their competencies and the way that the competencies are taught are a little bit different. So number one, no available curriculum. Number two, lack of experienced faculty. So, and that's obvious, because if the faculty is not experienced in the use of telemedicine, then the curriculum is going to lag. And on that same line, if there is no local use of telemedicine, right? We don't use telemedicine in our clinics and in our practices, then the faculty is going to lack the experience on how to use it and will not be able to teach the students. So those top three bullets are the three top reasons why telemedicine education is so hard to implement. The bottom three are grayed out, but I just want to emphasize, if there is not enough interest from the leadership, if the school is not behind the initiatives, then it's going to be impossible. So there has to be support from the leadership in order to implement these curriculums, which I had, and I'm very, very grateful that the school has supported me in this telemedicine course that we've implemented. Now, the American Medical Association back in 2016 adopted policy to encourage telemedicine education in medical schools, right? To study the most effective methods for telemedicine education, to reduce barriers to the education, and to encourage the AAMC and the ACGME to develop core competencies. This was in 2016. Last year, 2019, the Association of American Medical Colleges created a telemedicine competency work group, and this is led by Dr. Scott Shipman from the AAMC. And this group basically has been meeting on and off to develop ways and competencies in order to eventually develop core competencies that would be implemented and integrated into the medical school curriculum. So far, the group, they've done presentations like that one that I referenced at the bottom, but they haven't released anything official yet. Now, incorporating these telemedicine competencies into the curriculum. So now I'm going to make a disclaimer here. The slides from here on, the content of the slides is based on my own experience and my discussions with other experts like Dr. Krupinski and Dr. Marson from UC Davis and Dr. Rubin from University of Virginia, Dr. Weinstein from University of Arizona. So these are leaders and experts in telemedicine and education. So from their conversations and my research, I've developed the content of the next few slides, and this is what I based the course that I developed with. This is how I developed that course for UCF. So I divided these competencies in preclinical, clinical, and graduate levels. At the preclinical level, these students are digital natives, right? The students coming in the first, second year, they already have that foundation on how to use communication technology, digital communication technology, internet search, email, texting, how to use video, how to use audio, how to use social media. So that knowledge is there. The goal at this level, preclinical, is to relate and teach healthcare uses leveraging or using those technologies, right? So using their non-healthcare knowledge and then teaching them how to use those same technologies for healthcare purposes. That should be the goal, with emphasis on privacy, safety, and security, right? At that point, at that level, we should also introduce them to the basics or telemedicine 101 and some basic competencies. When we teach telemedicine 101, the points or the importance or the topics should be the historical perspective of telemedicine and how we've gotten to where we at, definitions and terminology, modalities, the applications, clinical sites, staff, and responsibilities. And then the basic competencies at this level should be how to build a physician-patient relationship via telemedicine, basic practice standards, HIPAA and privacy, quality and safety issues in telemedicine, and then telemedicine etiquette. And I developed these little tables, right? So we know the who, preclinical level. At the bottom, we know the what. We know to teach telemedicine 101 and basic competencies. We can teach this either via didactic or lecture interventions, interprofessional education, or via simulations or telehealth, right? And we can do this virtually or in person. So this should be, that's the preclinical level. At the clinical level, the goals should be to introduce the students now during their core clerkships, to introduce them to now more formal modalities and how these modalities can be applied into the clinical setting, right? Reinforce telemedicine etiquette, introduce the students to the virtual physical exam, touch on topics of ethics, digital divide, rural health, cultural competency. All of those are appropriate at this level, and also reinforcing privacy, security, and safety. This is a list of the competencies that should be addressed. And again, this table, the difference is that now I'm adding here clinical experience. So how to teach competencies at this level should include clinical experience, right? Shadowing at the clinic. So in order to achieve this, it would be important to then develop local use of telemedicine. So the faculty should be involved in either educational uses of telemedicine or telehealth or clinical practice, so the students can benefit from that. And then at the graduate level, the goals at this point should be to highlight more of the professional side of telemedicine. So at this level, the students should already have the basic knowledge, and the resident at this level now should be introduced to the business side of it, the telemedicine landscape, the market, right? Business models and how to develop a business, right? Because many would like to go out and practice on their own. So this is important. Understanding workflow integration. So planning, designing a program, implementing a program to fit within the workflow of the organization, how to do that. And then obviously understanding regulation. They should be taught basic concepts of state regulation and reimbursement, and always emphasizing privacy, safety, and security. Competencies remain the same. Now at this point, preceptorship is the emphasis, right? How can we allow our residents to treat patients and learn the basic competencies while they're seeing patients at the clinic, right? And I have to add that the AHCGME, within their guidelines, the AHCGME allow for the attending physicians to provide direct supervision for residents via telemedicine, basically. So as long as there are other faculty where the resident is, the attending faculty can provide supervision via telemedicine. So for example, if you have an internal medicine resident rounding in the hospital, the attending could connect via tablet or via a telepresence robot and round with the student or the group of students along with the patients. And that is acceptable as a way to provide direct supervision. Also during this COVID emergency, Medicare, it actually is allowing payments to allow residents to treat patients via telemedicine and get paid. So as long as the attending is supervising the residents, you know, the resident can be at home, the attending physician can be at home as well, and the patient can be at home, and the resident can treat the patient, and as long as the attending can supervise the resident, Medicare and CMS are willing to pay for those visits during this emergency. Right, so that's the end of the presentation. I know it's a lot, but I just added some addendums here. I want you to know there are some fellowships. There's a Thomas Jefferson University Telehealth Fellowship within the Emergency Medicine Department. There is also a Telemedicine Fellowship at the George Washington University School of Medicine, also within the Emergency Medicine Department. There are also a number of courses and certificates that anyone can take. You know, some of these are accredited by the American Telemedicine Association. I personally attended the Arizona Telemedicine program back in 2018. For the most part, there's a second page. For the most part, these are introductory courses. I want to highlight this on this slide, that first bullet. This is Waldo County General Hospital in Maine. They actually have a full virtual speech therapy and occupational therapy telemedicine program, and they provide a certificate, and it's accredited by the American Telemedicine Association. So speech therapists and occupational therapists that would like to learn more about telemedicine and how to provide services remotely to their patients, this would be a good course. And it's in Maine. I'm not sure if the course is, if the person would need to travel to Maine to do the course, or if this can be done online. But what I know of many therapists doing this sort of certificate, because mainly speech therapy and occupational therapy is gaining traction and is becoming a thing. You know, patients are at home or patients are in these rehab facilities. So using this technology can facilitate treatment. And lastly, I wanted to mention, for those who are interested in regulation and policy, the Center for Telehealth and eHealth Law is promoting a telehealth policy certification program with the goal to train telehealth professionals in understanding policy and regulation. Right? So the course has not been launched yet, but this would be a good resource for those of you who are interested in this sort of thing. It's been a pleasure. I know there were some questions, and I try to do everything in the 2 hours. But anyways, just touch base. If you have any questions, email me, call me, text me, check out my email, and I'll be more than willing to help you. So thank you for attending, and y'all have a good one, and be safe and take care.